I'm so sorry I couldn't be there with you in person. This morning, I will be speaking to you about the future of care. But before I begin my talk, I would like to say a few words about the institution that I represent. The Integrated Health and Social Services University Network for West Central Montreal, or CEUS as we call it in Quebec, is a partnership of complementary healthcare facilities, including Jewish General Hospital, 5 CLSCs or primary care services, including home care, 5 rehabilitation centers, and 7 residential centers covering the entire continuum of care across 34 sites. Treatment and care are provided by a staff of more than 13,000, including approximately 700 physicians. As I said, today I will be speaking about the future of care. But before we get to the future, I want to situate us in the now, and I would like to do so by telling you a story. A story of a man. Let's call him John Doe. It's October 10th, 2023. John is 49 years old and he's a construction worker. Though he knew he was overweight and he ate too much fast food and avoided exercise outside of work, he had never had any serious medical issues. And in fact, if you asked John, he would tell you that he thought of himself as generally healthy. But today, his heart was racing, he was sweaty, the room was spinning, and he felt like he was going to die. Once in the emergency room, after waiting in the hospital corridor for what seemed like a really long time, the medical team diagnosed John with a dangerously high blood sugar. They delivered normal saline and insulin and informed John that he had type 2 diabetes. Over the next few days, John was started on insulin therapy and also diagnosed with high blood pressure. An abdominal CT scan further revealed a 4.5 centimeter abdominal aortic aneurysm. A cardiac MR study confirmed coronary artery disease. A few weeks later, John had a follow-up visit with a diabetic specialist. He was told that he was going to need to radically alter his lifestyle. He had to inject himself with insulin several times daily, take multiple blood pressure medications, have periodic monitoring of the aortic aneurysm, and think about the possibility of cardiac intervention if his recently diagnosed coronary artery disease worsened. While he moved from appointment to appointment, often unsure what would happen next, John asked himself how all of this could have happened so suddenly without his knowledge and in this modern day and age. Scary, right? John's story is a tale of our current healthcare system, which is reactionary and fragmented, where care provided is uncoordinated, and where far too many patients develop serious chronic health conditions before anyone notices or tries to intervene. In fact, when you think of the healthcare today, do you empathize with John? Have you shared his experience? What are some of the thoughts that come to mind? If the words that you thought of are mediocre quality, poor safety, and high costs, you would be neither wrong nor alone. Despite considerable variation in health system design around the world, most countries suffer from similar gaps and challenges. Patient safety and quality have been a concern since the early days of structured measurements. Preventable harm to patients is all too common both inside and outside hospitals, and clinical practices are often not evidence-based. Although these gaps have been thoroughly studied and many interventions have proven effective in small-scale implementations, large-scale progress has been minimal. Most systems can't consistently measure outcomes that matter to patients and can't improve their health-related quality of life and overall function. Modern health systems often fail to provide care that is focused on patient and family needs and expectations, and often can't effectively involve patients and their families in the care process or provide empathetic care. Equitable access to health services is rarely achieved, even in countries such as ours with universal health coverage. The COVID-19 pandemic has exacerbated the situation, further reducing accessibility and equity. For all these reasons and more, economic sustainability of healthcare systems is elusive. Further health spending is expected to rise even further as populations age and get increasingly sicker. And while these issues have been present for decades and the healthcare systems fail to close them, it is clear that business as usual is no longer possible and that healthcare transformation is imminent. Why imminent? Because there are several major drivers of change currently at play. One is the demographic shift. We are an increasingly aging society whereby people require more preventative and long-term care, which is at odds with our system that is largely based on provision of acute and reactionary care. The next is digital revolution. Digital revolution has transformed the experience of banking, retail, travel. I and many like me fully expect that it will change healthcare as well. Consumerism is growing, and as people become more knowledgeable and active in their care, the health industry will need to become more person-centered, personalized, and more transparent. Another major driver is unsustainable cost structures across the developed world. It is creating a burning platform for providers, insurers, consumers, and policymakers alike. Next, the healthcare workforce is facing fundamental challenges. Workforce shortages seen in many countries will force adoption of new technologies to stretch the available workers. New specialties will require new health professions. Finally, COVID-19 has put strain on systems around the world. It has also brought about an incredible expansion of digital health and specifically telemedicine. All of these factors make it a watershed moment for healthcare transformation. What does that transformation look like? At Arceus, that transformation has a name and a path. It is called Care Everywhere. What that means is that for our healthcare system to evolve, we are looking to shift both operations and leadership out of the hospital. Hospitals today are typically responsible for the largest portion of spending in healthcare. To ensure its sustainability and adopt to the pace of time, Care Everywhere emphasizes the delivery of right care at the right time in whichever location is most appropriate, safest, and most convenient for the recipients of health and social services. How do we get there? By transforming services across several vectors, namely integration of care, digital transformation, shifting the financial models to those based on value rather than volume, and finally, by ensuring that healthcare institutions become centers of innovation. Let me elaborate on each. First vector is the integration of care. As we could see from John Doe's example, underlying the current healthcare failings is a critical underappreciated problem, fragmentation. Focusing and acting on the parts without adequately appreciating their relation to the evolving whole. This unbalance, this brokenness, is at the root of the more obvious healthcare crises of unsustainable cost increases, poor quality, and inequality, which is why changing the way clinicians are organized to deliver care must be at the core of value transformation. The first principle in structuring any organization or business is to organize around the customer and the need. In healthcare, that requires a shift from today's siloed organization by specialty department and discrete service to organizing into integrated care units, which in turn ensure that the various aspects of patient care work together harmoniously. What does that involve? Well, several components. Care coordination. Coordinators of care teams have to work together to ensure that patients receive the right care at the right time. This, in turn, reduces inefficiencies and prevents the duplication of services. Information sharing. Providers share patient information, medical records, and treatment plans, ensuring that healthcare professionals have access to a complete, up-to-date view of the patient's medical history. Patient-centered approach. The patient is at the center of care decisions. Their preferences, values, and needs are taken into account in the care planning process. multidisciplinary teams. Healthcare providers from various specialties collaborate in a team-based approach to address all aspects of patients' health, including physical, mental, and social well-being. Preventative and early intervention. Integrated care models emphasize preventive care, early intervention, and the management of chronic conditions to reduce the need for acute care and hospitalization. And finally, measurement and quality improvement. Regular assessment of outcomes and quality measures is a key component to ensure that the care is effective and efficient. What does that look like practically? During the last healthcare reform in Quebec, we reorganized into integrated university health and social services networks, or CUSs, as I mentioned in the beginning. This was a strategic move aimed at improving the coordination, accessibility, and quality of healthcare and social services while putting the well-being of patients at the forefront. These networks seek to create a more efficient and patient-centered healthcare system supported by research, education, and streamlined governance. At Arceus, we have worked to bring this vision further to life by creating integrated practice units, or IPUs. In an IPU, a dedicated team made up of both clinical and non-clinical personnel provides the full care cycle for the patient's condition. IPUs treat not only a disease, but also the related conditions, complications, and circumstances that commonly occur along with it, such as kidney and eye disorders for patients with diabetes, or palliative care for those with metastatic cancer. IPUs not only provide treatment, but also assume responsibility for engaging patients and their families in care, for instance, by providing education and counseling, encouraging adherence to treatment and prevention protocols, and supporting needed behavioral changes such as smoking cessation or weight loss. In an IPU, personnel work together regularly as a team toward a common goal, maximizing the patient's overall outcomes as efficiently as possible. They are expert in the condition, know and trust one another, and coordinate easily to minimize wasted time and resources. They meet frequently, formally and informally, and review data on their own performance. Armed with those data, they work to improve care by establishing new protocols and devising better or more efficient ways to engage patients, including group visits and virtual interactions. Ideally, IPU members are co-located to facilitate communication and collaboration and efficiency for patients, but they work as a team even if they're based at different locations. One of the biggest stumbling blocks to streamlining of care and quality assurance is timely access to data. To improve the quality of healthcare and social services and to ensure that clinical staff have prompt access to accurate health-related data, Arceus has launched an ambitious project to co-develop an innovative next-generation electronic health record based on the integrated care network model. Known as the Connected Health Record, or CHR, this complex multi-year undertaking will make consistent, updated information about each user easily available to staff on a single digital platform across all CUS sites. Uniformity of information and its easy availability are fundamental to the safety of healthcare users and the quality of their care. When all of the data about each user is eventually centralized in the CHR, the care teams will have the most accurate and up-to-date information at their fingertips, making it easier for them to arrive at thoughtful, well-informed decisions. The CHR will also have a significant impact on the user experience. For example, almost every patient has had the experience of coming to the hospital and having to repeat their medical history over and over and over again. When all of the information is finally collected into one uniform system, patients will no longer have to keep repeating themselves. Another important tool in support of integration of care is creation of a of command centers in order to streamline communication, encourage collaboration, break down silos, and empower action. In 2021, our CEOs has launched a new command center housed at our Jewish General Hospital, likely the first facility of its kind in Canada and possibly in North America. Our command center gathers and displays data about our integrated healthcare network, the elements of which I explained at the beginning. Our staff in the command center, or C4 as it's called, are able to oversee and expedite patient flows and transfers within the whole CEUS. Where once decisions were made in silos, the command center is now the hub that brings together the people with the right information to make decisions much more efficiently and much quicker, and where we're able to address any barriers or issues that can come up. As a result, we can make decisions in minutes and hours, not weeks and days. It has proven effective in critical situations, especially where decisions have significant outcomes and where the environment is changing rapidly. Our goal is to allow the team in the room to receive and react to information quickly to facilitate efficiencies where we might not have been able to do before. The second vector is the advent of value-based care. Payment systems will need to change so that the true product is total health rather than care transactions. Early evidence suggests that value-based payment models can indeed reduce spending per beneficiary. As systems transition to value-based payment models, the provider will no longer benefit financially from increasing services and instead will learn to focus on improving care, preventing complications and readmissions, and ultimately on delivering the best outcome for the patient. Incentives will evolve during the transition period. For example, a provider performing joint replacements may initially receive higher reimbursement based on preventing surgery-related infections. But with time, the payments will also be tied to ultimate success of the procedure as measured by the patient's functional status and quality of life. To focus on outcomes that matter most to patients and families, we must be able to measure those outcomes. Patient monitoring devices such as wearable technology and ambient sensors will let us measure functional status and mental status more accurately than we can now. Value-based payment will expand health organizations' responsibility outside the hospital and clinic and into the community and home. Today, we try to prevent falls and pressure ulcers at the hospital. Tomorrow, we will try to prevent falls and pressure ulcers at the patient's home. This expansion will redefine healthcare organizations. With the transition to new payment models that incentivize value rather than volume, the market will require solutions that are more cost-effective, delivering the same quality, yet at a lower cost. Technical examples include wearable fitness monitors and remote sensors. A less technical example would be walk-in services such as minute clinics that deliver care in convenient retail settings. Such disruptive innovations have been far too scarce to date in healthcare. As market rules change, so will the nature of innovation. The third vector is technological advances and the advent of digital health. Digital technologies are now integral to daily life, and the world's population has never been more interconnected. Innovation, particularly in digital sphere, is happening at unprecedented rate. Even so, its application to improve the health of populations remains largely untapped, and there is immense scope for use of digital health solutions. The possibilities are endless. Let me list a few of the most promising technologies and give you some concrete examples. Artificial intelligence, or AI, is a cutting-edge technology that enables machines to perform tasks that typically require human intelligence. AI has the potential to play a crucial role in transforming healthcare. It can, for example, assist healthcare professionals in diagnosing diseases, developing treatment plans, managing patient records, and enhancing patient care. Now, generative AI is poised to go even further, giving every individual access to not only knowledge, but more importantly, expertise as well. Already, one generative AI tool namely Google's MedPalm 2, passed the physician licensing exam with an expert level score. Another generative AI tool responded to patients' questions with advice that bested doctors in both accuracy and empathy. These tools can now write medical notes that are indistinguishable from the entries that physicians create and match residents' ability to make complex diagnoses on difficult cases. In not too distant a future, these tools will be securely connected to electronic health records in hospitals, as well as patients' monitoring devices in the home. As generative AI feeds on this wealth of data, its clinical acumen will skyrocket. Within the next 5 to 10 years, medical expertise will no longer be the sole domain of trained clinicians. Future generations of ChatGPT and its peers will put medical expertise in the hands of all users, radically altering the relationship between doctors and patients. Whether physicians embrace this development or resist it, it's uncertain. What is clear is that there's a tremendous opportunity for improvement in medicine. Today, an estimated 20,000 Canadians die every year from medical errors, while 150,000 die from mostly preventable chronic diseases and their complications. Virtual reality is changing the lives of physicians and patients alike. Looking into the future, you could travel to Spain or home while you are in a hospital bed, or you may watch operations as if you're holding the scalpel. VR is used in many situations, from training future surgeons and for qualified surgeons to practice operations. Patients are benefiting from these advancements in technologies as well, with pain management shown as one of the area of improvement. During labor pain, women are being equipped with VR headsets to allow them to visualize a soothing landscape, thus helping them with the pain. Patients diagnosed with cardiac, neurological, gastrointestinal, and post-surgical pain have shown a decrease in their pain levels when using VR as a stimulus. At Arceus, we are currently co-developing and piloting several technologies in the context of elder care and rehabilitation. Differing from VR, augmented reality is where users do not lose touch with reality and information is put into the eyesight as fast as possible. AR is becoming the driving force in the future of healthcare because of these distinctive features, both on the receiver's end and the medical provider side. For medical professionals, it could aid medical students to better prepare for real-life operations, as well as allowing existing surgeons to improve their capabilities. In fact, at our institution, we have pioneered the first application of the Microsoft HoloLens for use in real-time extended reality clinical support of a minimally invasive heart procedure. That, in fact, is the picture you see at the bottom. On March 15th, 2021, using this device, our surgeons completed the first end-to-end remotely guided transcatheter aortic valve implant replacement, a minimally invasive procedure to replace a heart valve. The teaching specialist in Toronto was able to remotely guide the Jewish General Hospital TAVI team of doctors through the procedure in real time at JGH in Montreal using the intraoperative extended reality platform. A bit of levity. Remember this? If, like me, you're a Trekkie, you must have dreamt of having only one all-powerful and supreme device, able to analyze and diagnose every disease just like Star Trek tricorder. With the rapid growth in healthcare technologies, we now live in a world where these kinds of devices exist. Closely connected with the future of healthcare and medicine, patients and individuals' empowerment is taking better care of their health using technologies like wearables, health trackers, and sensors. These are excellent devices that allow us to know more about our health and give us more control over our own lives. This technology has also given rise to the virtual care programs. These programs are growing because they improve outcomes at lower cost and they improve patient satisfaction. In January 2021, Arceus has launched our own program. The first of its kind in Quebec and known as COVID at Home, the program allowed specific COVID-19 patients to be discharged if their recuperation was progressing well. Thus, their home became a virtual world where Vital signs and other aspects of their recovery were regularly and remotely monitored by a hospital care team using remote monitoring digital health devices. Given the success of the COVID at home, the network has expanded it into a comprehensive virtual care program, which includes hospital at home, recuperation at home, and rehabilitation at home, and includes other medical and surgical use cases. Nanomedicine holds significant promise for the future of healthcare due to its potential to revolutionize the way we diagnose, treat, and prevent diseases. We could see nanoparticles and nano devices operating as accurate drug delivery systems, tiny surgeons, or cancer treatment tools in the near future. In fact, at our institution, in a process developed in collaboration with Starpax Biopharma Montreal, specialized bacteria known as magnetodrones are laden with anti-cancer medication and are injected directly into the tumor. Since these magnetodrones are sensitive to magnetism, their movement can be controlled with a magnetic field generated by Starpax's Polar Track device, which guides the magnetodrones to a precise location in the tumor. Since this type of therapy keeps the medication from circulating in the bloodstream, the patient is spared extensive exposure to chemicals or radiation whose side effects could be physically draining and psychologically debilitating. This technology is currently undergoing clinical trials. Once clinical trials have concluded, the treatment would have to be approved by the relevant health agencies before becoming available for general use. Robotics is one of the fastest growing and most exciting fields of medicine. Robot developments range from disinfectant robots or exoskeletons right through the surgical robots and pharmabotics. Exoskeletons did extraordinarily well in the year 2019. The very first exoskeleton-aided surgery was performed, and a tetraplegic man became capable of controlling an exoskeleton using only his brain. There are many applications for these robots, from lifting elderly patients and aiding nursing to assist patients with spinal cord injury. Loneliness is also alleviated by using robots as companions. They are also used in healthcare to help children with chronic illness and treat mental health issues. And finally, our fourth vector, closely related to advances in digital health, is evolving healthcare institutions into centers of innovation. The digital revolution clearly has a huge promise for improvement of health and social services. Yet, as we've mentioned before, despite substantial investments globally, few digital health technologies and companies have been able to develop technologies truly capable of transforming healthcare. One of the reasons digital health innovations fall short is because they apply a strategy to healthcare that was developed and refined in the tech sector, an entirely different industry with its own normative and methodological framework. Consumer technology startups often push quickly to get a minimum viable product to market and then iterate to improve that product based on what most resonates with consumers. Entrepreneurs and investors from the tech world mistakenly assume that this lean startup approach, which works well for products like photo sharing tools and meal delivery apps, should be equally successful for tackling any kind of problem. However, this strategy is ill-suited to healthcare, a much more complex and regulated industry. Digital health products must meet the needs not only of users, but also of a diverse set of stakeholders, from physicians, nurses, patients to regulators and insurers, all of whom have varying needs and perceptions pertaining to the adoption of new digital health products. Products, especially those considered as medical devices, must go through complex clinical and regulatory hoops before they reach the market and cannot always easily be redefined or adapted further once they're implemented. A better approach for healthcare is needs-driven innovation. Rather than leaping to invent a technology and then searching for a challenge it can be used to address, one starts by deeply understanding an important problem in healthcare and then designs a technology that is uniquely suited to solve it. Once implemented within a given healthcare environment, iterative feedback from all users is crucial to inform optimization in real-life settings. To that end, RCUS has created OHOT, a connected health innovation hub. Using human-centered design and a unique skill set brought for the first time into our CEUs, AHOT brings together healthcare professionals and private sector entrepreneurs to understand needs, frame problems, co-develop prototypes, and commercialize and finally integrate innovation. In its short existence, AHOT has truly made a mark in the realm of digital health innovation, having spearheaded dozens of innovation co-development partnerships and having introduced and integrated just as many existing solutions. In conclusion, it will not be easy to get to this new world, and it will be realized faster in some places and domains than others. However, if payment systems reward organizations and practitioners for doing better, I believe they will find ways to innovate, and successful innovations will spread rapidly. Some innovation will rely on digital technology and AI, but much of it relate to leveraging the techniques of implementation science, the scientific study of implementing research findings in practice, moving care away from hospitals, and bringing together health and social care. We can let the market drive health system change in a fragmented, uncoordinated, and reactive way, or manage the change in a coordinated and deliberate way to optimize the impact on patient outcomes and organization performance. We will need to take a proactive approach if we are to see these changes take shape earlier. All stakeholders, policymakers, payers, care recipients, and caregivers must be at the table to enable and deliver effective transformation. Now, as we contemplate all this incredible change taking place already, and as we imagine the change yet to take place, let us revisit our friend John Doe that we met at the beginning. It is January 1st, 2030. John woke at 7 a.m. with help from Siri, his e-personal assistant. As Siri showed John his schedule for the day, she reminded John that his blood sugar levels had been on the rise these past few weeks. They were now at a level that needed medical attention. John agreed to an appointment with his primary care physician, and Siri set an asynchronous consult with his doctor. By the time John was on the bus to work, his doctor had already checked in with a video message to John's smart glasses. I've been tracking the vitals and blood indices from your subdermal implantable patch, and it seems like you are on your way to developing over-diabetes, his doctor said. That means we need to start on a low glycemic index diet and make some other lifestyle changes. I have sent Siri all the details, and she will be building a personal plan tailored to your daily schedule and your personal preferences. Please let me know if you have any questions. I will also connect you with our nurse practitioner, who will be much more available to any issues you might want to bring up. John recorded a brief message back to his doctor with some questions. On his way back home, John negotiated with Siri on these new lifestyle changes. However, he was fine with most of them since he was enrolled in his employer's Healthy Life Incentive Program. Any points he collected keeping to his new healthy routines would convert to a financial bonus at the end of the year. John was happy he had agreed to have subdermal patch placed 5 years ago. Without it, he was sure his diabetes would have been diagnosed much later at a much more dangerous point, maybe even requiring hospitalization. Thank you for your attention. Please don't hesitate to reach out for questions or potential collaboration. Have a great rest of your conference.